Dr. Marlien Varnfield is a research scientist, health and biosecurity at the CSIRO. Her research focuses on the development, delivery of large-scale implementation of telehealth mobile health services. Specifically, she has extensive experience in care models designed to deliver and support self-management of chronic conditions such as cardiovascular disease and diabetes to patients within their home. Through involvement and management of numerous research projects, Marlien has studied innovative ways in ambulatory monitoring and management for the best health outcomes, creating new business and clinical service models using telehealth for the management of chronic diseases. And doing so, changing process models to accommodate best practice care for monitoring patients remotely. In addition to numerous national and international conference presentations, Marlien has extensively published in the field of chronic disease, self-management and mobile health. Thank you.
Thank you very much for the introduction. And as the previous speaker also mentioned, we use that introduction to try and get grants. So that's why it's sometimes more impressive than it sounds. And then I also want to say I attended the previous conference, and when I presented there, it was more on initial results that we had from the trial that I'll be presenting on now. I was all bushy-tailed and bright eyes then, and yes, we can do it all. So today I'm presenting results after we finished the trial, and we also now published the report. I'll focus specifically on user perceptions and compliance, and then also on organizational challenges. It is not necessary for me in this group to say or to mention the advantages of telehealth. I think we all are converted, and we do believe that there are potential for telehealth to improve management of chronic conditions. I think our challenge is to prove that to the world, and to do that we have to answer some questions like, can we really through telehealth help people to manage their chronic conditions? Can we really improve outcomes not only for the patients but also for clinicians and for the government? And then in improving these outcomes, can we actually reduce costs? So how do we answer these questions? It is actually quite hard. So CSIRO, with funding from CSIRO and from the government, undertook a trial. It was one of the NBN pilot trials. And the objective was to identify and model the impact of introducing telehealth to existing services. So we didn't want to create a new service. It was introducing telehealth into existing services or care models. And then in that process, we looked at service utilization, socioeconomic outcomes, impact on patients, their carers, and then also clinicians. What I'll discuss is acceptability and usability of these services, not only by the patients, but also by the clinicians. And then the very tough one, the effect of workplace culture and capacity for organizational change management. We were planning on doing a randomized controlled trial, but for various reasons we couldn't. So our trial design was a case-matched control, and in doing the analysis we used a BACI, or before-after control impact. And there we had mathematicians, statisticians, a whole bunch of very clever people working on that specific design. I'll just go back to this slide. Our trial sites, we initially started with 6, and it was spread from up in Townsville down to Launceston in Tasmania. We had 2 sites in New South Wales, and then 1 in Canberra and 1 in Melbourne. Our patients included, and they were identified, or the inclusion was they had to have at least 2 hospitalizations in the last 12 months, or at least 4 in the last 5 years, and then they had to have 1 or more of the following conditions. We included lung disease, heart disease, diabetes. We excluded cancer, and Parkinson's disease for obvious reasons, because they were supplied with a monitoring device where they couldn't handle the device if they had Parkinson's. So this is a device that we supplied, and that depended on the clinical condition of the patient, the measurements that they discussed it with their clinicians, the measurements that they would monitor. But it included blood pressure, pulse oximetry, a single lead ECG, and then spirometry, body temperature, body weight, but it depended on the condition of the patient. The device also allows messaging or video conferencing with a clinician, and then questionnaires could be administered through the device, and questionnaires there would be short questionnaires on COPD or diabetes, and then we also, because we were running a clinical trial, we administered some of the trial questionnaires through the device. The care models included in our trial, we had 2 sites in hospital chronic disease management units. We had a local health district, 1 trial site. We had the then called Medicare locals, we had 2, and then an aged care facility. Yes, so the reason why I'm not so bushy-tailed anymore, but I'm still going, is the challenges that we had to manage. We were funded by the NBN at that stage, and all our patients had to be connected to NBN. By the time we started the trial, after all the ethics and the agreements were signed, the NBN didn't roll out where it was supposed to roll out. So we were chasing test patients, and that's the reason why we also couldn't do the randomized controlled trial. We had to connect patients as quickly as possible in NBN areas where there was no NBN. So we initially connected all our test patients, and then we only could recruit our control patients afterwards. And anybody here who's a statistician will know that that is a problem. We couldn't find enough controls in some of the areas because we just connected everybody that we could as test patients. And then we had issues with compliance with the study. And in this case, it was not the patients. It was actually, we had, in some sites, not all sites, we had non-compliance by the project officers or by clinicians. And then also the fact that we had to change to the VACI design. And because of the slow rollout of the NBN, we couldn't monitor all the patients for 12 months. Some of the patients actually were on the monitoring for 18 months, and some of them only included in the study because eventually the funding also ran out. We monitored for only about 6 months. And once again, statisticians will know that that is an issue. But by the end of the trial, we actually enrolled 287 patients. We were aiming for 25 test and 50 control patients at each site. We almost got there in 3 of the sites, and unfortunately in 2 of the sites we didn't get to the numbers, and 1 of the sites we actually had to we discontinued with the site. You can see there that we ended up with quite an elderly population, and they were all either obese or overweight, if you look at the BMIs. So we did end with a population that was quite sick and elderly. And that is something that I would, if we should ever repeat a trial like this, one of the inclusion criteria is they had to be older than 50. So for our purposes, I think our population was too old and too sick. We had some withdrawals, and this is from the test patients, the ones that we connected, and most of these actually withdrew because of a change in their circumstances. It was not because they had any issues with the actual telemonitoring. We had some patients moving into high care facilities. We had only 2 who had difficulty with using the telemonitoring device, but one of them was actually, it was a language problem. So even though we had a number of withdrawals, I wouldn't say it was to do with the telehealth. It was more that our population was maybe too old and too sick. So we looked at the compliance, first of all, with their measuring schedule. Because we were running a trial, we expected the patients to monitor do their measurements every day. And the way we calculate or we looked at the compliance was to look at the scheduled tasks versus how often they actually completed those. We ended up with a total of 63%, which I think for the population that we had was really good. The parameters where we didn't have a very good compliance was, for example, forced spirometry. And I think in many cases the clinicians actually advised them that they really don't have to do it every day. And then compliance with the questionnaires. The questionnaires here are the questionnaires that they scheduled through the actual device. We also had questionnaires that were filled out by the clinicians when they had their baseline assessment. These are only the questionnaires that we actually administered through the device. Some of the questionnaires they had to complete daily, some of them weekly, some of them monthly. And you'll see the ones that they actually had to complete more often, the compliance was a bit less. Because it was a trial, I think when you do telemonitoring in real life, you won't expect a patient to fill out the questionnaire on user acceptance or satisfaction. You won't expect them to do diets and active Australia every now and then. So I think we did quite well on the 54% that we got on compliance. We had a questionnaire, and that's actually one that we did through the monitoring device. And we also had, if they couldn't, some of the patients preferred to do it telephonically with the project officer. We did have a questionnaire on user perceptions on the device, but then also on the service that they received. And you will see there that overall, most of them found the telemonitoring device easy to use. They felt that they could, with confidence, use that. And they also felt that they could incorporate the measurements into their daily life without too much effort. We asked them about the actual service, and you can see there that 90% of them will actually recommend the service that they received to somebody similar to themselves. And we also found that 90% of them were overall satisfied with the service that they received. These are just some patient comments, and most of the comments actually mentioned that it was like having a doctor at home, and there was somebody looking after me. So all in all, quite positive from the patient side. Now, these are the change management challenges. It is not easy to implement a new model into an existing model unless you really have a champion on the ground. In some sites, we didn't, but in most sites, we really had champions running with it. And that's, if you look at the numbers that we recruited, you'll be able to see which sites we actually had a champion running at. We actually had to decommission one of the sites because of patients not being recruited at all. We also had instances where the patients were cherry-picked. We had a person saying to us, but we don't want to use the telehealth monitoring because we're used to offering the face-to-face, and we have a BMW service. And I said, but you might not be able to afford that BMW service forever, so let's look at something that you can use instead of that. So I'm not here to present the actual results, but I thought it might just be good to show some of the results that we got in terms of the use of services. So we had a reduction in MBS, costs of about 24%. Unscheduled admissions to hospital fell by 24 to 36% over 1 year. We had a reduction in the length of stay, and mortality was reduced by 32 to 48%. Now, for our test patients, we were very clear on if there was mortality or not, or if there was a death or not. It was a bit harder for the control patients because we never had anything more to do with the control patients apart from a baseline questionnaire. So we relied on other sources to find out if any of our control patients was deceased or not. So the ones that we reported are the ones that we were 100% sure they were actually deceased. And as I mentioned, then we had a high acceptance and positive user perceptions from our patients. We believe in a perfect world that there should be a role or the most important role in this telehealth service is the clinical care coordinator. And that is a role that was created in some of the sites. If you have a champion as a clinical care coordinator, you can successfully implement a telehealth service. Just in summary then, the main reasons for withdrawal from the trial for the patients was, in many cases, change in circumstances. The compliance with the daily measuring and completing the questionnaire was generally good if you consider the cohort that we were working with. It is well accepted by most of the clinicians, not all of them, but very well received by the patients. And it is not that hard to implement a telehealth service, providing you have clinician or clinical buy-in. And I've worked on other projects where we did mobile health, distant monitoring, and if you have a champion on the ground, it will work. If you don't have the buy-in of the people who are actually dealing with the patients, then it is not going to work. And then, as I mentioned, we see the critical role of the clinical care coordinator in any telehealth program. Thank you.